Assalamu alaikum. I am Dr. Azizul Haque, going to present congenitally corrected transposition of the great arteries with atrioventricular block. A case of non-diabetic hypertensive non-smoker male patient of 30 years old who presented with complaints of aggravated effort intolerance, fatigue, palpitation and slow heart rate. According to the patient, he had been suffering from recurrent effort intolerance and fatigue during exertion since his childhood, but he gave no history of generalized bluish discoloration during exertion, fever, chest pain or syncope. His birth history was uneventful and all members of family are in good health. Investigation shows all the biochemical parameters are normal except he is mildly dyslipidemic. Resting ECG showed bradycardia with 2:1 atrioventricular block, 24 hours Holter monitoring showed occasional fast, second and intermittent complete heart block and significant numbers of extrasystole. The ECG shows the 2:1 AB block. Now the echocardiography, which is the main diagnostic tool. This showed first step was the identification of situs in best assessed in subcostal view, in which the aorta, pulsatile aorta is on left side of the spine and the collapsible inferior vena cava is on right side of the spine, that is situs solitus. Second step is identification of atrioventricular discordance. Best assessed in apical fourth chamber view showed left atrium connected with morphological right ventricle through the tricuspid valve and right atrium connected with morphological AV through the mitral valve. Left atrium is recognized by drainage of the pulmonary valve and morphological RV recognized by the apically displaced septal leaflet of tricuspid valve and moderator band. This displacement of septal leaflet of tricuspid valve not in strain range, that is about 5 mm per meter square. Next, this is parasternal short axis view at great braces level showed the two parallel circle in which the aorta is positioned anterior to the pulmonary artery. Normally, the pulmonary artery is situated anteriorly and wrap around. This is ventriculo-arterial discordance. As the patient is and there is no associated other structural cardiac anomalies such as VSD, strain anomaly, left and right ventricular obstruction. As the patient is a case of congenitally corrected transposition of great arteries in the absence of other cardiac anomalies with serious AV conduction block, he is advised for transplantation of permanent pacemaker implantation. And the patient was implanted with a dual chamber pacemaker. During pacemaker implantation, there is some difficulty. As the right atrium connects to morphological LV through mitral valve, it was quite difficult to insert the TPM lead. The position of the ventricular lead of the patient permanent pacemaker was also difficult because it enters the morphological LV instead of usual RV. However, a good result with stable efficient pacing was achieved by using a screw in ventricular lead. After implantation, patient quickly achieved relief of his symptom. At follow-up, he was quickly asymptomatic and happy. This is the 12-lead resting ECG showing the ventricular pacing and atrial tracking. We plan to follow up this patient to detect any future systemic ventricular dysfunction by echocardiography and if necessary by cardiac MRI. Thank you.